So what happens when you perform a free gracilis muscle transfer and you don't like the result that you get? What are the things that we can fix about that? And what I would say is fix what you can see. So if the flap looks bulky, go after that bulk. Open up the skin flap. You can ride right down the superficial surface of the gracilis muscle, and I turn out that skin flap and debulk the fat on the undersurface. The fat often hypertrophies, I think because there's some lymphedema trapped in there. Go after that, thin it extensively, and you can even remove the superficial layer of the muscle, remembering that the innervation is coming from the deep surface, so you're not going to denervate that muscle by trimming off the most superficial surface. Second thing is, if the inset vector isn't quite right, correct it. Open the flap, dissect, slide all the way down the gracilis. If there's a piece of fascia lata there, you can literally run right to the medialis and either release an inset suture that's making the muscle pull in a funny way, or put one in if it's not pulling in an adequate way. The third thing is that if the gracilis muscle is foreshortened and the oral commissure is too lateral, take down those inset sutures and introduce more space between the distal gracilis end and the medialis. Likewise, if the oral commissure sits too low, in other words, there's still an element of facial ptosis, you can dissect the gracilis, being very careful to preserve the neurovascular pedicle, and tighten the entire muscle. The key is not to leave something that's changeable. The final thing that I would say is you want to stabilize as many midfacial landmarks as you can. So I've become a huge fan of stabilizing and opening that nasal valve by lateralizing those nasal cartilages, stabilizing the philtrum, stabilizing the nasolabial fold, and even stabilizing the midline lower lip. Fascia lata, palmaris longus, a single ethibond suture, whatever it might be, but don't overlook the power of midfacial stabilization during that operation.